drying system. I'll just tell you what that system is. No financial disclosure. If you look in your textbooks, you have got a 4-color corneal drying system. I learned that when I was doing my fellowship with Professor Dua in Nottingham, and we had the 4 pens in our pockets all the time. It's been cumbersome. I've never seen someone doing it religiously, and I don't do it because we don't have the 4 pencils with us. So what I've done, I've developed a 1-pen system in which with one pen you will be able to you will be able to mention the different conditions. The plan of the talk is how to draw the templates, common corneal conditions, anterior segment conditions, RSN pupil, ocular surface, normal corneal pathologies like keratoconus, keratoplasty, VKC, and degenerative dystrophy. So I've developed the science for all of them, and the beauty of that is it is in 1 color. So you have got a pencil, black, red, whichever pen you have got, you can actually donate all of them. So first of them, what are the templates? This is the template for the cornea. Do you want to point to that? Point to those. This is for the cornea, and this is for the iris. So if you've got the 4 radial spokes, that means you are drawing the iris. And thanks to Dr. Atif Chauhan, who helped me out in this one. Then this is how you measure it. The cornea is 11.5, but you imagine it is 12, and you draw 2 lines like this and 2 lines like this, imaginary lines. So you have got a 4 into 4 millimeter rectangular. So if you draw a lesion like this one, like this lesion, this is covering 3 parts of this rectangular and 2 parts of this rectangular. So this is 5 millimeter horizontal and 3 parts of this rectangular and 2 parts of this, so it's 5 millimeter vertical. So this ulcer is 5 into 5 millimeters. That's how you can actually measure them clinically on your rough diagrams. So every section is 4 millimeter horizontally and 4 millimeter vertically, and you can draw the lesions like this. Then this is for the anterior chamber, and this is for the dorsal and bulbar conjunctiva. Now, the common epithelial lesions. Common epithelial lesions are, and common stromal lesions and common endothelial lesions, and I'll give you the signs for all of them. All these signs are on www.myeyeacademy.com, so you don't have to remember them. You can go to that website, or you can go to the YouTube channel, and you can find all those signs. First of all, this is the epithelial defect, and if it is filled with the same color, that is the corneal ulcer or abscess. Then if you have got a corneal opacity, that is in the increasing density. So if you have, because the horizontal lines, that means very faint opacity, horizontal and vertical lines, that means moderate opacity. If you have got the third cross lines, that means moderate to severe, and if you have got the fourth cross line, 2 cross lines and 2 horizontal vertical lines, that means it's a dense opacity. So that's how you can actually categorize the opacity in your drawing, as well. Then this one is the fine punctate staining. Second one is the coarse punctate staining, and this number 6 is like filaments, a sign for the filamentary keratitis. Then this one, straight lines are for the deep blood vessels, and wavy lines are for the superficial blood vessels, because the deep corneal vessels are straight and superficial ones are wavy. These flower-like structures are for the bullae, and these little dots are for the epithelial edema. So these are the epithelial signs, all in the 1 color. Doesn't matter which color pen you have got. Then these wavy lines are for the descendant membrane, and the cross lines are for the stromal edema. And this is again the corneal opacity as we have just described. So this is the descendant membrane folds, and this is the stromal edema. Then is the thinning in the cornea. So if you have got this little opacity, which was for the epithelial defect, plus 1 line, that means 25% thinning of the cornea. 2 lines means 50% thinning of the cornea. 3 means 75% thinning. And this one is corneoscleral thinning or melting, 25%. And this one, circle with the straight line, which is like a D. That means this is the descendant membrane, desmetocele. So this one is for the desmetocele, and this is for 25, 50, 75% thinning. Then these are the corneal lesions. So this one is for the ulcer. So you have got roundish, make the drying of the ulcer and fill it with the same color. So that is ulcer. Ulcer with the 25% thinning, 1 line. with a 50% thinning 2 line, 75% thinning 3 line, and this one is the corneal ulcer with 50% thinning and superficial blood vessels growing into the cornea. Then this one is for the corneal perforation, so draw the perforation and cross it, and that is for the corneal perforation. Welcome Mariam, we were waiting for you.
Excuse me, I was in another session.
Yeah, that's fine, we understand that. Yes,
Sorry.
have a seat, please. It's okay, Doctor, you can sit. Now, this is again the endothelial lesions. This sign is this part of the G, so this is for the cornea guttata. This part of the P you draw it, and this is for the pigment of the endothelium, and this part of the K is for the keratic precipitates of the KP. So these are the signs for the endothelial lesions. Then anterior segment. This one straight line is for the hypopion, and straight line with the vertical lines is for the high femur. Then you can further elaborate it, and this one is for the clot. So if it's the irregular line, that is for the clot. Then if you want to further elaborate it, 1 line means 1 millimeter high femur, 3 line means 3 millimeter high femur or hypopion, 2 lines mean 2 millimeter high femur or hypopion, whichever you have drawn. So you not the straight line is just for the hypopion, and with the vertical line it is for the high femur, and it depends how many horizontal lines you have drawn. 1 line for 1 millimeter, 2 for 2 millimeter, and 3 for 3 millimeter. This one at the bottom here, this is dots with the 3, so that means plus 3 cells, and this is lines with 2, that means plus 2 flare. So you can actually draw the flare and the cells in that as well. Then this is the template for the iris, the vertical spoke, and this is for the pupil, 4 circular spokes, 4 radial spokes for the iris, and 4 circular spokes for the pupil. And this is, pupil is being drawn, and these crosses are for synechiae. At the margin of the pupil are for the posterior synechiae, and at the periphery for the anterior synechiae, and these radial spokes on the pupil is for the pseudoexfoliation. So this is how you draw the pseudoexfoliation as well. Then is the iris. This is the iris, you have drawn the iris. This one is iris with the pupil, this one is iris atrophy, and this one like iris cyst. This triangle is for the PI. This is the iris incarceration into the cornea, and this is the iris new vessel. So this part is first part of the end, so that denotes iris new vessels. If they are at the margin, you draw them here. If they are at the periphery, you draw here. You can access all these slides from www.myeyecademy.com or from the YouTube channel. Everything is there. This is thanks to one of my colleagues who helped me in this sign. This is for the pterygium. Pterygium with 1 arrowhead means 1 millimeter, 1 millimeter pterygium. With 2 arrowheads means 2 millimeter pterygium, and with 3 arrowheads means 3 millimeter pterygium. So you can actually just between drawing, you can denote whether it's a 1 millimeter, 2 millimeter, or 3 millimeter pterygium, and depending whether it's temporal or medial, you can draw it according to that. Then is the ocular surface. This part of the P you take it here, and that's for the papillae, and this part of the F, that is for the follicles. And this is for the conjunctival congestion, coarse corneal staining, and this one is for the Danon. So this one is raised here, and this one is depressed here. So that means there's a swelling which is causing corneal thinning. So that is for the Danon, and this one is for the black. These signs are for the mebomitis, and these straight line wavy lines are for the blepharitis. Then on the common corneal conditions, this smiley face is for the keratoconus, and this is keratoconus with the head striae and with the warts lines. Then we do a lot of corneal surgery nowadays, so this one is for the keratoplasty. This one at the bottom here, 1 arrowhead means you have got 1 port, so this is for the DMAC. DSAC is 2, because when we do the DSACs, you have got a top port and the second one for pushing it. So this is for the DSAC, and in the DALC you have got the recipient and the donor cornea one over the other. So the 2 circles means the patient has had the DALC. So this one is for the DALC, DSAC, DMAC, penetrating keratoplasty, and corneal stitches or any other stitches. Then this one is for the refractive surgery. That means the refractive surgery has been done, because normally when we see the patient with the refractive surgery, there is no clue that the refractive surgery has been done. So if in your diagram you have drawn the plus sign, that means the refractive surgery has been done. And if you have, very often the patient comes to us and you say you need CXL, and the patient says I already had it. But if there is in the diagram, there's a crossover there, that means the previous surgeon has done the CXL. So this is the sign for the CXL, and this is the sign for the refractive surgery done. This is the DKSA signs: limbitis, papillae, giant papillae and follicles. And there are no signs for the dystrophies and degeneration because they are uncommon and you don't have to draw them. If there's a dystrophy or a degeneration that you want to mention, you can write it, because I first tried to make the signs for them, but that was making it more confusing. So just to keep it simple and practical, we have just done it. Just done it for the common corneal conditions and not for the degeneration and dystrophies. Thank you very much. You can see all these signs on myacademy.com or on the YouTube channel. The whole talk is being loaded over there, and you can see and you can give your suggestions. Thank you very much for your listening. Thank you very much. I welcome Mariam Haraj. Yeah, she's here, and she was lost somewhere. She was in another session. And thank you very much. Welcome here. And I welcome Huda Ricci. She's here, and I think Sami Al-Arabia is not around. So the next talk is by Mariam Haraj, and that is about the keratoconus in children. Please.
Thank you very much for your invitation for this Magnified Congress. I'm Mary Harris from Morocco, and I am happy to share you my experience about keratoconus in children, clinical and therapeutic particularities. So we know that the physiopathology of the keratoconus is not known, but we know to have a basis genetic, and with environmental factors, the corneal epithelium will release cytokine, interleukin-1 and TNF-alpha, and then the keratocytes are stimulated to have abnormal proteinase and reduction of proteinase inhibitors. So this fragilistes the stroma, and we have central corneal deformation. So what can we act upstream for the environmental aggression on ocular surface pathology that we can do? We can take care of irabine and surface pathology. For genetics, no way, because we have no genetic therapy yet, and we must do a family diagnosis. The goal is in children is early diagnosis before the advanced stage, and the need to resort to corneal transplantation. So no this very severe stage. Keratoconus in children is severe and highly progressive, and with huge severe allergy. In our country, we have many children with keratoconus and vernal keratoconjunctivitis. The video, please. And so we have now the treatment of this severe allergy with cyclosporin 2%. We have good efficacy allowing the wearing of corticoids, the reduction of inflammation of the ocular surface in the long term. So this is very important to prepare this ocular surface for the surgery, to have no complication with the cross-linking, and that the child can tolerate the contact lenses after. This example of preparation with cyclosporin, and when we have ocular surface scan, we can adapt we can do the cross-linking and to adapt the child. The keratoconus is it's often also asymmetric because we have asymmetric rabin, like this patient, 14 years old, has the left eye who rub his eyes. We have a severe keratoconjunctivitis, and we have a severe keratoconus in topography, unlike the right eye, we have just a little asymmetry in the topography. Keratoconus is advanced progressive keratoconus in child. We have the keratoconus is progressive. So look at this topography after 6 months for this child. The climax become 25 and the pachymetry at 362. Before it is 64 and the pachymetry 400. So we must to have not severe stage of keratoconus in children. We have to define the population at risk of keratoconus. So what is the population? It's when we have atopic tear, when we have allergy, conjunctivitis allergic, when we have vigorous eye rubbing, and we have family keratoconus and family diagnosis, when we have syndromic association, Down syndrome, etc. So we can do early diagnosis with screening. How? We can do the early diagnosis by corneal topography, and for who? It's for the population at risk, we show now, and when we have appearance and evolution of myopia, recent and or progressive astigmatism, especially if we have contrary to the rule. And he developed a myopia and astigmatism under the rule, and when we do the topography, he has tinted, and we do the topography because he have conjunctivitis and he is having his eye, and we discover keratoconus and with high order aberration with coma at 3.2 handle. So management strategy of keratoconus for keratoconus in children, we must first manage ocular surface pathology, allergic testing, management of allergic conjunctivitis. After secondly, we do visual health education. It's very important to inform about keratoconus disease, allergy, eye rubbing, cross-linking, impulse of contact lenses, and stop eye rubbing, information and education of the child and his parents. After, we must slow down the evolution of keratoconus. So cross-linking in children is systematic, and it's in international consensus. So it must be APF, the same protocol for the adults. The cross-linking, it's very effective. We have more flattening of the cornea, and the healing is very fast. The follow-up must be very close because there is possible progression of progression post-cross-linking, and the epion no effectiveness. Donc, if we want to do epion in children in first stage with vascular visually 10-10 and with close follow-up. The close listing for thin cornea. What's even we have a thin cornea, we perform cross-linking. First, we use the cross-linking assisted by contact lenses developed by Susan Jacob. We had good results, but the effectiveness is 20%. After Now we are doing the new protocol. It's the Symp 400 cross-linking protocol developed by Hafizi. So we adapt the fluence and we adapt the UV type to the thickness of the cornea, and we have this table with the we measure the thickness of the stroma, and we have the time for irradiation by the UV. The results is very interesting, and now we do that from 21. After cross-linking for the children, we have to correct the visual acuity, and the treatment is optical treatment. It can be glasses in early stage, but we must fit the children by rigid contact lenses. Recovery of near normal visual acuity, very good visual quality, and as soon we have the astigmatic plus than 2.5. The all stage of keratoconus is very important. All stage of keratoconus are adaptable with lenses. It will be rigid contact lens, subscleral or scleral or hybrid lenses. The scleral lens is very interesting because it have a very good tolerance of this lens which pass in front of the cornea and the lens and land on the sclera. Large choice of geometric parameters for each zone, adaptation of strong corneal deformation, good tolerance in case of allergic conjunctivitis and dry eye, good adaptation for young people and children without the risk of loss, displacement or foreign body under the lens. We must be careful for the anteriors of contact lenses. We must eliminate an allergy flare and a bad adaptation. So we must have excellent fit and no stress zone. Like this child who have a flat fitting of his contact lenses, just we do a new fitting, and the lens is tolerated and the visual acuity rise. So treatment for keratoconus in children, even we have a strong ectasia, thin cornea and opacity of the cone, cross-linking plus the lenses, rigid or scleral lenses, is the treatment for the children. Prior preparation of the ocular surface is the first step, and stop iRaben and continuous follow-up, because we can have progression after. This is clinical cases. We have flattening of the cornea, and we adapt. We do a new fitting for the lens. This is venal keratoconjunctivitis. So we prepare the ocular surface by the cyclosporine, and after we do cross-linking assisted by contact lenses for thin cornea, and after we fit with scleral lens. So it's finished. To conclude, keratoconus is often severe and progressive in children. It affects his social and educational development. The advent of cross-linking has greatly reduced the use of corneal transplants. Our strategy is to do everything, not to transplant the children, units of information and education of the child and his parents. The cross-linking and contact lens couple is offered in all cases thanks to the new cross-linking protocols for thin corneas and advances in corneal contact lens material and design. Only the central opacity is subject to corneal transplantation. Thank you.
Thank you very much, Miriam. And the next speaker is Sami Al-Rabai, and he's going to talk about PTK.
Assalamu alaikum. Customized PTK. Management of keratoconus, everybody knows glasses, hardening lenses, cross-linking, and then you know corneal ring and keratoplasty. Number 4 is customized PTK with or without cross-linking. And then why we have patients, when you give them the glasses, they don't see it well. If they are -2, -3, whatever, and then you give them the glasses, they don't see very well. This is because they have another order that you don't correct to the glasses. You have another order which is high order aberrations. It is not the low order aberrations that is being corrected to the glasses. And high order aberrations, what are these? Aberrations are different from the classic or the exact or the perfect system to the patient. So whatever the difference is there, the machine will consider it as wavefront. And wavefront is either low order, which can be corrected by glasses, sphere and cylinder, or the high orders, which are not corrected with glasses. And we should tag Cornea because he's the one who made this pyramid, which tell us. And if you look at the pyramid, it's a big one. It goes up, down here. It's not that one. Number 0 is not being counted. Number 1 piston is not counted for us. It is for physicians. Starting from here, number 2. Number 2 is the low order aberration. And why we call it number 2? Because there is only 2 aberrations. Here, 1, 2, 1, 2, and here. This is astigmatism, and this is astigmatism, and this is sphere or cylinder. If it is red, it is minus. It's blue. If it's blue, it's minus. If it's red, it's plus. And then from this line, going down, it's the high order. These are the ones that are not being corrected with glasses. These are the ones we are now going to attack. If you look here, it's number 4 because they have 4. Number 3 because they have 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. And then here, number 4. 1, 2, 3, 4. 1, 2, 3, 4. So the lines are now 2, 3, 4. It is the number of aberrations. And then in the middle is the spherical aberration. But this one is plus and minus, but here spherical aberration, it doesn't belong to these two groups. And these groups in the minus, and these, see that minus, and these groups are exactly the same, but in the plus. And the minus and the plus, what is the difference? The plus are in the main meridian, 120, 180, and 927. And the minus are the oblique, okay? So they are the same. Look at this one, the same. So you know now what is in the left, what is in the right, and you know when we said the third order or fourth order means how many aberrations in it. And as we said, this is the low order, corrected by glasses, which is defocus, either plus or minus, astigmatism, and then you go down, these are the coma, and this is the spherical aberration. These are the trefoil. As a matter of fact, these 4 and this one are the main ones for us. And the machine looks at when we correct it, it doesn't look at the shape. It converts the shape into wavefront error. And then it corrects the wavefront error, changes it into another type of wavefront, which if you translate it to the topography, it comes this way. So the machine is not trying to correct the shape, correcting the wavefront error and end up with good shape, okay? The same story here. Look at this. Machine changed it and changed it into regular instead of irregular astigmatism. Just by playing on the refractive error. And why we said customized PTK? Because customized PTK means that the energy distribution is different to where we need. If you have a plain PTK, the energy distribution is equal, so all the tissue will have the same energy, so you are having replicating of tissue. But if you have customized, so energy will be higher here, will be nothing here, so you can take the highest one gradually until you get really a good surface. And centration is important, not only because you want to correct this error, you have to be exactly on it, but if you are putting your energy on a good place, you are inducing another error. So we are not correcting, we are inducing another high error if there is no centration or there is tilting. So you have to have registration. Registration of what? Registration for the shape, for the location, for the magnitude of the abnormality. And if there is cyclo-torsion, all our patients, they do have cyclo, you have to detect it and correct it, and you have to treat on the visual axis, not anywhere else. Okay? And then, what tool? You are using PTK, but what tool? Is it you are looking for treatment of function or shape? If you are treating function, you go for wavefront. If you are treating shape, you go for topography guided. So don't just listen. Topography guided only for shape, and it is not wavefront. Topography guided is topography guided. Wavefront is the whole ocular pathology, the total eye. So these are two. Now look at this shape. This I used it. This is the before. If you have a good shape, so this is topography guided. If you have bad shape, you are not looking for the shape. You are looking for the function. Because sometimes you have an abnormality on the surface of the cornea that's been corrected by another abnormality down, either the back of the cornea or the lens. And if the machine looks at them at neutral. So when you look at function, you don't correct them because they are correcting themselves. But if you do topography, you are removing one and you are leaving the other one. So you are still facing with another one. So don't look at the good face of this girl. Look at her function. Okay? It eats a lot of tissue, but it doesn't give us the same function as the wavefront. And then, finished. Okay? Now, this is the angle cover. The topography guided, because you ask the patient to look at the light, so the topography guided goes immediately to the center. While the wavefront guided, it looks to the inside the eye through the pupil. So this goes, the wavefront guided, it goes through the wavefront guided, it goes to the center of the pupil, not the angle cover. And you have to shift this, and this is what happens. We will pass all this, sorry, we have to shift it. The machine has to tell us, please shift my treatment from the pupillary axis to the visual axis in order to have good treatment. So the treatment will be 1, 2, 3. We start with plain PTK, and then customized PTK, and then if you have some tissue, you go for treatment of spherocylinder, okay? So our plain PTK, we said there are many types of PTK. This plain PTK, you will see it's fluorescent as long as it is on the epithelium. And once it is breakthrough, you will see the breakthrough as a black spot. You see it here? Stop, thank you. This means okay, this means that if it's normal cornea, the breakthrough will be in the center. But if in topography, so the breakthrough will be at the thinnest part of the epithelium, which is the top of the cone. You can see it is infranasal. But why it looks like this? Because this is the way I'm looking at the patient. And we change it from here to there, from irregular astigmatism, biregular astigmatism, only by topography guided. Do you see that? Now, if you have patient with whatever error, you can give him ICL, or you can give him whatever you want, clear lens extraction. He will have good vision because there is no more high order vision. His astigmatism is regular anymore, not irregular. And don't over-treat. Don't be happy with your over-treat. This is bad. But you can decrease the size to get better result. I don't have time to explain to you this, but this is very acceptable result if you look at the astigmatism here. And then, so the machine change into regular, and then you can add some correction, as we said, to have a perfect result. You may say there's nothing here, but if you look at the difference, if you look at the root mean square value, it was something around 2, it become around 0.7. Normal root mean square value 0.3 to 5. If I reach 0.7, I'm really happy. This patient is happy from 2.7 to 0.7. Only by wavefront. And these are different types. I'm finishing, alhamdulillah. You see, all these are different types only by treating wavefront, no correction. You see how look there? They look beautiful. Thank you very much.
Thank you very much, Shamik. And the next speaker is Huda Ravi, and she's going to talk about accelerating CXL.
She covered everything. I think Mariam covered all my lecture. Nothing for me to say. But Dr. Sami, great talk.
ultrasound greater. I'm doing the same for keratoconus. I'm doing PTK with cross-linking. So let us see. So it's just repetition for your presentation.
Is Miguel Richichi in the audience? Miguel Richichi? No? Oh, he hasn't
So today I'm going to talk about accelerated slash cross-linking in children. I work in UAE, and in UAE we have a lot of keratoconus, really a lot. Same in Oman, Saudi, Bahrain. I think it's very high in Gulf area. And as Mariam she said, there's a lot also a lot of cross-linking for Moroccan people. So I was surprised. I did a lot of work and we have keratoconus.
I'm confident that in Morocco we have an epidemic of
Yeah.
keratoconus
Yeah,
and severe keratoconus.
but I'm surprised. Why? Is there any allergy in Morocco?
Yes, we have allergy in the south of Morocco. We have many allergies. Keratoconjunctivitis, vernal
And the way
keratoconus.
they come young and aggressive, seniors and aggressive stage 3, I'm really surprised. Anyhow, so we need to handle this. It should be handled. It's
Now
a
we have
devastating disease.
yes.
Yes. So pathology, everybody knows pathology of keratoconus, sorry. It is progressive thinning of a cornea that it lead to coning of a shape with irregularity, astigmatism, and if it's not treated, it will lead to blindness at the entrance of the blindness. Onset, it starts first, the gate of life, become more aggressive, it depends on the severity. And the earlier that we have keratoconus, the more severe. That's why we are really interested in treating keratoconus in children. Prevalence, as we say, is very common in Middle East area, mainly in Gulf. In Saudi, they found one, I don't know, this is recent study, 1 in 25, which is really high. And about 40% of corneal graft, they do it for keratoconus. Also, it's common in Pakistan and India. Okay, let's see, it's clear. Let me change my location. Factors that may play a role in the progression of keratoconus, genetic, it's more common in male. I don't know why. It's caused, as they say, by iron, but recent study also they say iron is not a factor in pathology of keratoconus. We need to look for that. Well-known atopic disease and iron, contact lens wear, abnormality in the collagen that lead to hyperplastic joint and after refractive surgery. Associated systemic disease, atopic down, Ehler, as Miriam she said, I don't want to repeat it, and other ocular disease, retinitis pigmentosa, retinopathy of opportunity, and DKC. In children is very important. Why? Because usually the children, they don't complain, they don't say what they have, unless we found the poor vision, and when we do the investigation, we find that they have keratoconus. Also, it's important to retain poor compliance. They don't put the treatment unless the mother they run over them. So this which make the disease more progressive. And as we said, it's more they have rapid progression than in children. So the standard treatment for keratoconus nowadays is cross-linking, and this should be done as soon as we found it in children. No need to wait for progression as an adult. And the early detection is very important. Sinus symptom, it's the sign symptom of allergic conjunctivitis, and the symptom of poor vision because of conical shape of a cornea, which is myopia and irregular astigmatism. Management is a long list of measures, started from the glasses, contact lens, RGB, bicurve contact lens bag. All is mentioned by Miriam, Biggie bag, but I just want to focus about recently the new clear lenses, which found to have really comfortable for people with keratoconus. Medical treatment, steroid, antihistamine, and the role of cyclosporine nowadays in keratoconus is really important. I put all my patients with keratoconus on cyclosporine more than 1 year, even after cross-linking. I think it's the anti-inflammatory and immunomodulation of the cyclosporine diet to play a role in the keratoconus. And I think also keratoconus, it's an inflammatory process that lead to progressive thinning of the cornea. We have so many types of cross-linking. We have conventional, which is 30 minutes. We have the accelerated, range from 4 to 8 minutes, pulse, continuous, topo-guided, intercorneal lens with the cross-linking, dark, and PKP is the last stage. So cross-linking first found by Dr. Fiozella, and the first protocol, it was a Drosten protocol. It involved removal of epithelium, then sucking cornea with riboflavin 0.1%, and then treated the cornea with ultraviolet light for 30 minutes. And the power is 3 milliwatt. That's the difference between the old and the new way of treatment. Accelerated, it depends on the equation. Irradiation multiplied by time, it gives us the dose. So, before the power, it was 3 minutes. By 30 minutes, it gives us 30 milliwatt. Nowadays, the power is 30 milliwatt, and the time is range from 4 to 8, and we are delivering 30 milliwatt. So it's excellent for the doctor and for the patient. The ultraviolet light range is, as you know, between 366 to 445 nanometer. And we have two types of fraction in the cross-linking. It's type 1, which is the delivery of radical oxygen, and type 2, which is the oxygenation. The most important part of cross-linking is the oxygenation. That's how the reaction is occur in the cornea. And the radical riboflavin and reactive oxygen interact with the corneal protein tyrosine and tryptophan, and that's how it leads to the cross-linking between the corneal stromal fibers, and it will lead to strengthening of the cornea. This is the idea. So the method what we have, we did 25 eyes of 15 children. Actually, this study is on. I did it on 2018 and follow up to 3 years. So I did, of course, a lot after that. But this is already finished and submitted for the research day in our clinic in our country. Sorry. So I didn't change the data after that. And the age of the children, it was the youngest 9 years, and the oldest it was 19 years. The routine examination, we did the vision, the K-max, topography, comparison of the materials, and preoperative examination, the Sitram, Goldman, all these routine tests. So the accelerated, what we did first, it's the application of as anesthesia, and then I did epi off of 9 millimeter. Then I usually measure the CCT by ultrasound just to make sure that the corneal thickness is acceptable. Then saturation of the cornea by riboflavin 0.1% for 10 minutes. Then treatment of the cornea by ultraviolet of 7.2 joule per centimeter of 30 milliwatt per power for pulse light 1 second on, 1 second off for 8 minutes. Why 1 second on, 1 second off? The 1 second off, it allows oxygenation of the cornea, and it will give us a good result of a cross-linking. And this is, I think, the best treatment for the cross-linking. Okay, so post-operative follow-up 1 day, 1 day, 5, 1 week, 1 month, 3 months, 6 months. The most important part of the crossing, after crossing, is looking for demarcation line. The demarcation line, this is the line, it's the line between the treated and untreated cornea. And the deeper the demarcation line, the most tissue are involved. The deeper, the stronger cornea. The deeper, the longer term of stability. The deeper is the more refractive error changes. So, demarcation line, we look at it exactly 1 month after surgery, and it can stay up to 2 months, 3 months after that it will disappear. So this, when you look at it, it is more than 250, so that means you have a good result. Actually, it is between 180 to 250. So this is the first mark after the surgery that we should look for it, and this would give us a clue about successfulness of our surgery. And this is, as you can see here, here 239 micrometer. It's calculated from the epithelium till the demarcation line here. This is just one of my patients that I did.
From 56 to 53 within 1 year, and that I come 63 within 1 year.
Okay, so here we are.
We've got the next session due here at 11:30, please. It's near. I think we have only spent 10 minutes, and we've got 2 more speakers, and we've in the next
Okay,
session.
how much I have?
No, your time is already.
I'm done? Okay, sorry. Okay. Okay, this is important for me because here it shows the K marks, pre and post op, and it can show the, I think there's
reflection in the K-max, except
and this is study of Hafizi. It shows because before this is on Zoom study, I sent it on Zoom.
But I'm sorry, you have to finish because Mary has
Okay.
I'm sorry.
Thank you. And the most important recommendation, there is no need to wait for progression of keratoconus in children. Do it as soon as you see it. No wait.
Thank you very much, Uda. Actually, there was a bit confusion. We were told there is no other session here, but actually there is another session at 11:30. I've requested that we take another 10 minutes. We have got 2 more talks. Mary will do it, and then I may or may not do my talk here. Okay, Mary, please, and try to finish in time, please.
I will try to speak about how to liberate visual rehabilitation in severe keratoconus without recourse to corneal grafts. So why try not to go to the transplants? If we think the DAG
That does not
so that does not dispense either contact lenses or post-transplant conservative surgery. And now we have technological and therapeutic advances, so we can use it not to do a transplant. Progressive keratosis in thin cornea is the one of we can do a graft, and the closing of thin cornea is not developed by the new Parfait Hafizi, and it's the sub 400 protocol. So its efficiency, and if we have thin cornea, we can do with this protocol, and we have good results. Keratoconus, so we can use if we have a huge deformation of the cornea, and we have the contact lens, the rigid contact lens is not stable on this deformed cornea. We can use scleral cornea. Scleral cornea is a very good tolerance of lens. We have large choice of geometric, and we have good tolerance, and it's adapted for children and for adults. Also, we can treat all allergy before fitting contact lenses, and we prepare the ocular surface to fit with scleral lens. What is the advances in investigation? Now we have corneal OCT and anterior segment OCT, who give us topographic is more reliable in OCT assay than in shampoo camera if severe deformation or scare. Separate pachymetric maps, epithelial, stromal, and total maps, and we have Fourier analysis who separate the refractive. Donc the Fourier analysis is separate the regular astigmatism and the asymmetric in the anterior axial map. And when we correct the patient in this axis, we have more visual, correct visual acuity. This, for example, is a case with here we have the astigmatism topography. The axis is 135. The best correct visual acuity with the axis is just 410. And when we take the axis of the asymmetry in axial map, it's 110. The visual acuity rises to 810. So the difference just we change the axis of the astigmatism, and the visual acuity is more or better. So this patient is a good indication for toric ICL because the visual acuity is good, and he had in post-operative ICL incorrect visual acuity. It's 910. We developed transepithelial PRK and the abrogated PRK. Dr. Sami has demonstrated the efficacy to just remove the high order aberration, and the visual acuity is very interesting, and we can correct by glasses or by ICL implant phakic eye. So with abrogated PRK, we have low TC consumption. We indicate even of internal corneas, and the low order aberration can be corrected by glasses or by ICL. This we have this example with combined. We have a severe keratoconus, and the K-max is 16 plus than 16, and we combine surgery. We perform first intracorneal ring to decrease the high order aberration. This is
the map after cornea rings. So with cornea ring now we have the visual acuity is better, and we have a pachymetry at 461. The result is already good with the intracorneal ring, but I can be further refined by a topographic guide per K since the CCT is plus than 450. So this is post-topo guide per K, and current visual acuity is 1010, and this is differential map with the two techniques, with first by intracorneal and after by PRK. This is a very severe keratoconus, and we have now new intracorneal rings that are asymmetric. The thickness of the thickness of the ring is different, and we could put the part which thick in the zone which is very ectatic. So this example, so we have a ring and asymmetric. We have 200 and 300 in thickness, and the length is 330, and we have good results with this patient. Now with 810 with this ring. ICL phakic implant in keratoconus, it corrects myopia and astigmatism, comes as a second intention after regularization of the cornea central by PRK toponic or intracorneal ring. So after correction of irregular astigmatism, high degree aberration, combined chirurgy and intracorneal plus phakic implant ICL. So this patient have intracorneal ring first to regularize the cornea, 2 rings, and after we do OCT, and he received this is the surgery. We haven't time to do that. Oops.
Your time is up, Marie.
I conclude. The last. The last slide. So you see here that the patient have a ring in the cornea and phakic implant ICL behind the iris. The visual acuity is very interesting. So to take home message, all these technological advances, whether in a functional and anatomical analysis of the cornea and the anterior segment, or in new medico-surgical and optical therapies, have allowed us very satisfactory functional rehabilitation on feign very ectatic cornea which would be sacrificed between other hands. Perseverance, dialogue with the patient with comprehensive care, ocular surface patient education and follow are necessary. The graft remains a first indication for central opacity and true endurance to scleral lenses. Thank you.
Thank you very much, everyone. We had a last talk which was about the Pakistani innovations in keratoplasty. I'll skip that one because the next session the people are waiting here. So thank you very much, everyone, for being here, and please continue with the next session. Thank you very much. Thank you.